Pennsylvania and also in California. So it is my pleasure to join you today.
So Judy, you've got control, so just click on your screen and you can advance the slides.
Okay.
And click again, there you go, perfect.
There we go, okay. This is the only commercial we will have today. We're very thankful for our funders in order for us to present today. And here's my contact information. I will also give you my email at the end of this. If you have any questions following the webinar, feel free to reach out to me. We are there as not only training, but also as a technical assistance provider on this topic. And we also have created an online healthcare toolkit that you might want to take a look at, and there's a link for that. And it's by profession. So if you're an EMS provider, there is a section for you for information on the latest tendencies, protocols, and other resources you might find interesting.
Do you need to go back?
Yeah, there we go. Okay, so our call to action, what we're going to be looking at today is our response to domestic violence or intimate partner violence victims. We're going to be looking at health and safety assessments, interventions, and documentation, also referrals. We're not going to be turning you into advocates today. We're going to be focusing on pretty much your health and safety while you are there taking care of that patient, which I know is your #1 priority. So this is from a quote from an EMS response. Intimate partner violence is the only category of crime in which the perpetrator frequently remains on the scene, expecting no negative consequences and actually perceiving intervention as a violation of their rights. And they will attempt to manipulate your care and also to limit the conversation that you may have with that victim and also your patient. When I responded with advocates on the scene at one time, for an untrained officer that was there, of course, they split the two apart. You're probably familiar with that. And as they did that, the abuser was saying, look what I have to put up with. She was very emotional. She was upset. He had really got her going. And then she was very fearful that she was going to be harmed. So, of course, she called 911. So the response from that person was, look what I have to put up with. And the untrained officer was like, yeah, really, yeah, I understand. That must be really hard for you. Well, it wasn't hard for them because they purposely put that together, that whole situation. And that person was coming back to that apartment to get that person's SSI check so they could go gambling in the local casino. So that was their purpose for coming there, and she was refusing to give him the check, of course. So that's what was happening. So the American College of Emergency Physicians, this is their policy statement. It said it should be incorporated into initial and continuing education of EMS personnel, and I think that's, thank you for Project ECHO for putting this together. And we're looking at recognition of victims and their injuries, understanding the patterns of abuse, how does that affect their care, safety on the scene, preserving of evidence, and documentation requirements. So that's going to be our focus for today. So why EMTs and paramedics? Well, the focus for law enforcement, most often we had law enforcement responding on the scene with us at all times because it was one of the most dangerous and unpredictable situations for law enforcement, as well as be thinking about that you as an EMS responder. But they might be more candid with you and forthcoming with information rather than law enforcement. Because if they weren't in danger, well, they're going to be in danger. That's why they called 911. But thinking about if they take them to jail in Nevada, they have 12 hours before they are released and go back to that environment. So that person's thinking, okay, I'm in danger right now, but after 12 hours, if they take them, then I have to plan, oh, what's going to happen to me? He's really going to be mad. And then you're going to be going on another call, most likely. So if they're more candid with you, you can take care of them, get them a referral to get to an advocate, whether it's in the community or to a national hotline, so they can do some quick safety planning. So then identification of whether this is a situation of intimate partner violence is that first step in interrupting that violence and getting them the resources that they need. And also your documentation may be the only documentation they have of the abuse at that home environment. So it's important that we look at our role as one of support, information, and then resources. So here are our objectives today. Well, we're going a little bit too fast. So we're going to try to go back, there we go, and look at the scope of the problem. So we'll look at briefly at some statistics. We're going to define intimate partner violence. You may be thinking, okay, this is very common as domestic violence, but the healthcare community has adopted the term intimate partner violence because it's more inclusive. Domestic, you might think man, woman, maybe a marriage situation or they're living together, but we need to expand that definition because it exists in same-sex relationships as well. So that's why we're using the term intimate partner violence. We're going to be looking at the dynamics of this relationship and then the common medical conditions that you may see. And then also looking at safety, routine screening, intervention, document, and appropriate referrals. We're not going to spend a lot of time on details on screening, intervention, and documentation. Project ECHO has other presentations that I've done specifically on those topics. And you can go online and take a look at those and then view that for more details. So the terminology and definition. So it's a pattern of behavior, assaultive and coercive behaviors. It is meant to establish and maintain power and control over another person. It's not an issue of anger. Anger will make it worse, but it's cold, it's calculating, it's manipulative. So whether that might involve physical injury, emotional abuse, in fact, survivors tell us that emotional abuse is the worst because it's everyday, it's constant. Humiliation, name calling, monitoring what they say to their friends. It's just the constant emotional abuse. The bruises, the broken arms will heal, but the emotional abuse is what's worse for them. Sexual assault, economic coercion, with the elderly are more vulnerable to this. Adult children seem to be one of those people that are manipulating that economic situation. Social isolation because they don't want anyone else to take them away, to lose their target. If you have someone doing everything that you want in a relationship, you're not going to want to give that up. So they isolate them. Stalking, even if they leave the relationship, then they may be stalked after that. One of the things I also want you to be thinking about today is the medical. They may or may not be able to go to a healthcare provider depending on what the manipulation is. There was a caregiver, and this is not a partner violence, but it's a caregiver who was taking care of a quadriplegic patient. And this person was put outside in the rain, taken the battery out of the wheelchair and told, if you don't get me a check for this amount of money, then you're going to stay out here until you do that. And I'm going to make sure that no one else will ever be a caregiver for you ever again. So that medical care, obviously neglect, manipulation, and then sometimes you'll see in a healthcare office, they'll say, gosh, you know, every time that person comes in, they're not following their treatment plan. Well, they may be diabetic, and the abuser was holding their insulin. Because I'll say, you need to do this, then I will give you your insulin. So you may find that from all different aspects of the control they have over their healthcare situation. Medications as well, particularly with the elderly. They may be taking their pain medication, selling it, either over-medicating them or under-medicating them. So you're going to see both of those things. And then, of course, intimidations and threats. based on some of the examples I told you. So underlying, it's all about power and control. It's not about anger. So let's take a look at the statistics. How bad is this situation? Well, 1 out of 3 women have experienced physical violence by an intimate partner at some time in their life, but here's the 80% of women report verbal abuse. I don't want you to think this is a woman's issue. It's not. Even though about 85% are women, these statistics are what is reported to us. So we know there are more men out there. So you should be screening all of your patients. Men, women, gender non-conforming individuals, transgender individuals, their rates of abuse are 50%. So all of them should be screened. 1 in 5 women will be raped, and then 50% of American women other than rape. And then, like I said, even if they leave, they may be stalked as well. The highest rates of stalking among our young people. For teenagers, 1 out of every 3 teens are experiencing abuse in their life. So talk about the influence of technology on them, and stalking and monitoring is very high. And then if we look at Native American populations, you'll look 50% higher rates than other ethnicities. And then we look at 1 in 5 for rape, 1 in every 3. And then not only within their culture, but outside of their culture, 86% are not native, non-native men. And then pregnancy. A lot of times you'll think that, okay, a woman who's pregnant, that's their child. They'll want to protect that child and not expose them to abuse. It's not the case. They will target that unborn child in order to manipulate that person. 40% of women, pregnancy was unintended compared to 8%. They will put holes in condoms like the reproductive coercion. They will forcibly remove an IUD from an individual. In fact, some physicians now are cutting the strings off the IUD just to help avoid that from happening. But that's how the extent that some abusers will take. So you want to be sure if there's bleeding, it may be a forcible removal of an IUD. So we know this is a serious situation. We're looking at homicides, the high statistics here. IPV, a precipitating factor not only in those with the homicides, but also 1/3 of suicides. You will see that on the news all the time, homicide and then suicide. And then 3/4 involving an intimate partner. And here's homicide for pregnant and postpartum women. Violence Policy Center, every September, we hold our breath every time this is published. If you're not from Nevada, you can go online and take a look at the top 10 states. Number 3, we ranked number 3 in 2016. It's 2 years back, so that was September 2018. But go online and take a look at that study so you can see what's happening. So knowing that this is a real serious situation, let's take a look at some more of the dynamics of the relationship. I want to let you know that there's no way to predict, there's no red letters on their forehead saying that I'm an abuser or I'm a victim. It comes from all different classifications, all of those listed. No one is left out of this. So why don't people leave? Here's one patient's explanation. My doctor asked me why I just didn't leave in a very irritated and demeaning way. He looked at me like I was stupid, and it never occurred to him that I had left, that my husband just tracked me down again. He doesn't know my husband keeps threatening to kill the kids and me if I leave. I'm afraid and I'm scared. That could have been a much different outcome than her feeling afraid and also scared by simply screening and assessing and providing resources to that patient. So here are some of the barriers. I'll share with you today that I am a survivor of relationship abuse, and I was in an 8-year marriage And originally when I reached out, we didn't have hotlines, we didn't have emergency shelters because it was a private matter. You just don't talk about this. And everything on the outside looked great, but every time I went for some help, these are the comments that I got. So I went to my friends, first of all, and they said, "What did you do to deserve this?" Okay, that wasn't real helpful because, again, I was being blamed for this. And then I'm stupid for staying with him. So now I'm not only being abused, now I'm stupid. And of course, the question that a lot of people ask, why don't you just leave? Well, if it's my fault, I felt an obligation in this marriage to help that person. Um, and for me to be a partner in this and see what I could do to help. But nothing seemed to work. I went to my mother, and that wasn't real helpful because she gave me this: "You've made your own bed, now lie in it." Platitudes are not helpful to anyone. So that was another door that was shut to me. And then I thought, if anyone can help me, then my pastor would, because he refused to marry us without me going to counseling with both of them. And he had all his couples he was going to marry for counseling. So I thought if anyone would understand, he would. So this is what he told me: "You need to pray about becoming a better wife. Your role as a wife is to serve your husband and your family." And then he also added, "Never deny your husband." So I left his office that day with some scriptures and told I need to pray to be a better wife. None of these were helpful. The person that helped me was a nurse on an EMT crew. I was seeing her on a regular basis. She was a volunteer nurse working in a hospital, but volunteered for our rural ambulance crew. And she said, "Judy, you know you don't deserve this abuse." I said, "What are you talking about? Everyone else is telling me it's all my fault." She says, "You don't deserve this abuse." Her simple comment, if you can't do anything else other than saying something like that and offering some assistance, that changed my life. That moment in time got me thinking a lot deeper and thinking, you're right, it is not my fault. There are things that I can do. So eventually, after getting some counseling, and then also not couples counseling, just my counseling, we tried the couples counseling. That did not work at all. Another opportunity just to abuse me in front, and I clammed up. So we don't recommend couples counseling. But because of her, I was teaching high school at that time. Because of her, I went back to school, became an EMT, and then also became a volunteer for that same ambulance crew. And we responded together. So anytime there were situations of this response, I knew what that person had been going through and the frustration and feeling fear. So we were able to provide those supportive responses, and they could get some help and get some referral resources. So that's why, another reason why I'm so privileged to be a part of this presentation today. So thank you to all you EMS providers. So I also wanted to let you know other barriers to leaving. It will increase in violence without intervention and also escalate in intensity over a period of time. We have not seen situations where it gets less without intervention. That's why it's so important to respond appropriately and then give a referral resource to a community-based domestic and sexual violence advocacy organization. Typically, it may take 7 or 8 times before they're safe enough and they decide to leave. It took me 8 years in order to do that. So you got to give people time. They will decide to leave when it's appropriate for them. And then also, if they have a disability, this is so important for us as EMS providers. It may take an average of 12 times. So again, important resources. They may break their wheelchairs. They may not have the devices they need in order to be independent, because that's a way to control that individual. So if you're finding you're giving referral resources for continued abilities, either walkers or wheelchairs, that's what's happening. They may, if they're deaf, they're going to destroy maybe their hearing aids or their eyeglasses or anything that would help them be independent. but I'm in large bold print here, the most dangerous time for their victim is when they decide to leave. Large percentage of homicides occur when they leave. So saying to a patient that you need to leave, you need to get out of here, is not the way to approach a patient. It is the most dangerous time. So it is an option, but please get them to an advocate so they can get safety planning, and then they can make a decision for them. Okay, so here's some of the medical conditions. There's nothing unusual here, but you're going to see this happen even over a period of time. It's been a long time since I've been out of that relationship, but you know, you still get triggers, and there still may be migraines and irritable bowel syndrome, but it's not happening a lot. But to be aware of that when you see a patient, when you're asking about history of that patient, you may want to include questions about, have you ever been in a relationship where you felt fear? Or have you been abused at any time in your past or currently? Because these kind of things definitely affect the rest of their life. And then, of course, sexual assault with sexual discomfort. So those kind of things may be new to you with the extent of time. There's the diabetes symptoms because they're being manipulated by getting insulin or not getting insulin. Anxiety, depression, that's not unusual, but abusers that we're hearing, they're purposely infecting their partners with HIV or other sexually transmitted infections, purposely infecting them. So we need to be aware of that, and that's a matter of control. If you want control over a person for the rest of their life, you either have children with them or expose them to HIV. They will certainly remember what you've done. High blood cholesterol, heart attack, heart disease. You think this is an adult situation? We're finding with teens that teens are developing this at this time, and then it remains through the rest of their life without intervention. Okay, and here are some injuries, some photos. Woman up the top, it's a little hard to see, but she received a pretty hard slap. You can actually see where the fingers touched her and bruised her. And the arm that you see, that's a defensive wound. So there was indication of a photo from a hospital in order to document that. And also dental trauma. Dentists do not screen for relationship abuse. So they're coming back with other injuries, so we don't want to forget about that. Of course, injuries during pregnancy. So at 18 weeks, the baby started kicking, but at 22 weeks, so did the father. Remember, it's all about power and control. Here's some complications you may want to be aware of. I'm not going to review all of them. I think they're pretty obvious. But you'll see like, oh my gosh, they're pregnant, but they're still smoking or they're drinking. Well, if you have to make survival decisions on a daily basis, you know, there are survivors who are using tobacco and alcohol in order just to get by day to day. So if we're not addressing those issues about the causes or the reasons for them doing that, we're really missing the proper health for this patient. I also want to talk about this because it's missed a lot. So look at the statistics. This is from 2018. We're seeing up to 92% physical injuries to the head. Nearly half are reporting strangulation. So we also need to look at this and whether they're suffering traumatic brain injury, loss of consciousness. Patients are not thinking about this. They don't recall the loss of consciousness. They're not identifying the traumatic brain injury. In fact, when I was doing a training for volunteers, there was a young man who was giving back to an organization, and we talked about traumatic brain injury. And he said, you know, What you have just told me, my doctors never told me. He was a survivor of traumatic brain injury. He was thrown out of a moving vehicle and landed in the road. And he still wanted to give back. But he said the accommodations, they talk all about his condition in the hospital, but nothing about day-to-day living and how that affects the life that he was living. Okay, you're going to see some photos here of some methods of strangulation. Also be thinking about the petechiae that you might be seeing. We know there are other causes for petechiae, but I also want you to think, possible strangulation here. And look at the average per victim for strangulation, 5.3 times. So you're going to see this again and again. I'm so sorry. Also, petechiae located inside the eyelids. Not as pronounced as the first individual, but still definitely there in an elderly patient. And then here's some other wounds that you might see. And also here in a younger patient. I wanted to include this documentation chart for you so you'll be looking about these are some of the changes that you might be able to document. This was shared with me by the San Diego City Attorney's Office. So please incorporate this. Feel free to incorporate this into your assessment charts. And here's one person who experienced this. I was strangled in Santa Monica, California on July 24th, the point that I blacked out. When the Santa Monica paramedics arrived on the scene, they said my vital signs were stable. Neither the Santa Monica police nor the paramedics suggested that I go to the hospital. I did not go to the hospital. The perpetrator, the man I've been in a relationship with, was arrested for attempted murder within the hour. And then he was released sometime within the next 48 hours. I was never notified. No explanation to me. He nearly murdered me that night. She was never notified about the release. I'd be thinking within the hour what could have happened to her and whether there might have been some traumatic brain injury. Lack of oxygenation, she had blacked out, but not suggested to go to the hospital. So please, as you're looking at this, please assess for strangulation and also traumatic brain injury. The I was never notified. This took place in California. They have now passed quite a few years ago the Marsy's Law. Recently in Nevada, back in 2018 in November, we passed Marsy's Law, which actually has expanded the rights of victims that they will be notified upon a release. So if you're interested in learning more about that, particularly as EMS providers and knowing what those victims' rights are, you may want to go Google Marsy's Law, and then you can find out what those are. So not detailing all the aspects of the power and control wheel, but I wanted to reemphasize it's the emotional abuse, teens, elderly, economic control, and also spiritual control. I'm not going to let you go to church until you do this, this, and this. I'm not going to let you participate in this religious activity until you do this, this, and this. The rose on this is part of a stalking process. There was a young teenage girl who was struggling. She had broken up with her boyfriend, but didn't tell her people at work. So when she went out to her car every night, she noticed a rose on the hood of her car. And everybody said, "Oh, how romantic is that?" Well, she didn't tell people that she was being stalked, that was not a romantic gesture to her. And sometimes that rose would be inside the car. So when we're talking about the escalation of feeling fearful and scared, she never knew that who was lurking around her car. She didn't reach out for help, said, "Will you walk me to my car tonight?" Not that. Didn't tell her employer. I mean, the abuser could be there anywhere, but just the simple thing of a rose can really make a huge impact on how a survivor feels. I wanted to share this with you since you are going into the home at times. And when I train law enforcement, I encourage them to make sure they go through every bedroom. They have difficulty on the scene sometimes determining who the primary aggressor is because they're both arguing and going back and forth. But as the law enforcement officer went through this particular home, you'll see this is a crib. There's a child in that crib. And what that abuser told that mom is, she said, if you ever leave, I will kill you and the child. So to emphasize that, they put a loaded shotgun above the crib. So talking about intimidation and coercive control, is that person going to stay with that child and protect them? You better believe they are. So be on the lookout for things like that as you go into the home. I also wanted to take a look at some of the other things other than rape. We think about sexual assault and rape pretty much closely together, but they may involve some other things that you might need to be aware of as you're looking for injuries, particularly bruises around the breast or genital area. But there are some other things. We have the STIs that I mentioned earlier, but also the influence of spiritual practices and culture that may be involved in sexual abuse, and you can see that at the bottom, that example there. So our role as EMS. Many of these calls are not identified as IPV. So it is important to evaluate every call, every patient, and know when there's a need for law enforcement. I'm going to assume that most of you have law enforcement responding along with you, and usually a fire department fire truck that comes along sometimes. In fact, when I've had to call, I've actually asked for no lights and sirens, and also don't need to send the fire department. But depending on the severity or the scene safety, all are welcome in order to secure that scene safe for you, safe for every responder, and also for the patient, of course. And also law enforcement officers tell us it is the most dangerous, unpredictable, and can be volatile. So I would say treat these calls the same as they would, dangerous and also volatile. There's no reason why you have to feel, if you don't feel comfortable going into the house, go back to the ambulance, talk about what options, and if the police are not there yet, wait for the police to help you secure that scene before you go in. I really want to make a mention here of knowing yourself well when responding comes to these calls. Because the statistics are so high, there are survivors among you. You may not know that yet, but they are survivors among you. The likelihood, because there I was an EMT giving back to my community. So really think about yourself. What are my limitations when this kind of call occurs? What are my strengths? And I definitely had strengths because of my knowledge. And then my own history. Will I be triggered by observing or talking to a patient or caring for this patient? Really know yourself and what you can do for self-care. So if there's an opportunity for you to have vicarious trauma education, please take advantage of that. I mean, you don't need an IPV call to need care for vicarious trauma. It's just a part of being on call while you're there taking care of a patient. So here's some safety tips. Obvious dangers. Look around as you're approaching the residence. Look at the yard, outside the building. Is there lawn furniture kind of everywhere? That may mean there was an argument outside. Look at tools that are around. Chemicals. All of those can pose a danger to you. Are there children around? Pets? What are those conditions? Where are the adults? Are there other adults? Where are they located? Obvious weapons on the scene, and then any evidence of substance abuse. Empty beer cans strewn all over. How about previous calls to this address? You as a responder may know there are previous calls, but that would be nice for dispatch to share that with you, and then a history of any suspicious calls. I know the first thing we want to know, okay, what do we expect? How do we plan? Do we need oxygen? Do we need this? Do we need that? And then getting ready to respond to take this equipment with us as we go in. But knowing this ahead of time, kind of a step ahead. Stay alert, listen, wait. Do you hear yelling or sounds of a struggle? Make sure you identify yourself when you respond and knock on that door as an EMS provider. They may think you're law enforcement. So if they're not there yet, make sure you identify. That may seem obvious to you, but not so much if you're involved in an argument that's going on inside the house. Were you met at the door and then denied entry by someone who says, oh, the person's fine, they don't need medical care? Anything else that's concealing information about them, they will try to manipulate you and actually care for that patient. Keep your crew, your partners inside at all times. Never split the team. Very important. Consider using a cell phone versus a radio, because particularly, well, my experience in rural communities, almost everybody had a radio and they're listening into law enforcement response and emergency calls. So consider using that cell phone rather than your radio if you want to communicate to law enforcement or to dispatch. Identify all possible exits for escape. Let the occupants lead the way and then maintain a safe distance as you follow them in. Potential problem areas: kitchen, obviously potential weapons, bedrooms, concealed weapons, fewer escape routes, and then bathrooms, no escape route. So I would suggest, rather than going back unless they cannot be moved from those areas, maybe if you still need to care for them, do it in the maybe living room. But just be aware if you need to go into those particular rooms. Don't ask any questions about possible violence or no display of sympathy. Wait until the victim's in the ambulance and away from the abuser, because you don't want them to overhear what you're talking about, because they will grill. If they decide not to transport, they will grill them afterwards, so that may actually escalate the danger they're subjected to. Just remember, no scene is ever fully secure, and then removal of that victim is the best thing to do. So, patient interview. Most important is their medical care. What if you can't get them alone to assess their injuries? Is that person hovering over them? They will. And if you move them to another room, they may still be listening. I'm a big proponent of saying HIPAA, because we cannot care for them without that. Ask them to retrieve something like a towel or a blanket, and there's the HIPAA law. Sorry, we cannot treat the patient because of close proximity. If law enforcement's there, they can remove them, but just remember, there's going to be animosity there. And if they're in another room, they may be eavesdropping, so also be aware for them. Abuser may say, oh no, you're not transporting, or attempt to control, so be aware of that. If they do not speak the language that you're speaking, do not use family members to interpret. Do not. Because once they do interpret, they're going to be cross-examined following what's happening in the care that you're giving. Do not use family members. While your assessment's routine, it can be, remember, it's traumatic, degrading, and can be a life-changing event for a victim. Just the simple comments from my friends and my mother and the people that I loved and trusted really damaged my healing process. So the victim will all the time, before they're going to answer any questions from you, they're going to be looking at your body language, your demeanor, verbal language. There was a nurse in a hospital who actually apologized for screening before the patient was admitted, and the abuser was right next door, right there, beside them, sitting in the chair beside them. If you're in an ER and there's a curtain between you, not the best place to assess for relationship abuse. But make sure you're looking at those questions non-judgmentally in a non-threatening way. And recall that trauma can really affect the way a patient recalls and responds to medical questions. When I train law enforcement, they expect a patient or a victim of sexual assault to respond in a very logical manner and know point by point by point what happened next, what happened next. That's not going to happen with a victim of trauma. The best explanation I can give you of what that person's been through, think about everything that happened to them, the scene, the smells, everything, the people, the room, all on Post-it notes. And then if you take those Post-it notes, put them on a desk that is the worst messy desk in the world, and then put some on the wall, put some on the ceiling, put some on the floor. And then bits and pieces come back to them, not on a logical basis, but bits and pieces over time. So if you as an EMS provider can establish that trustful relationship, bits and pieces are going to come back. Well, saying, well, oh, they're making up this situation. This can't be happening. Well, for them it did, but in bits and pieces. So remember that when you're talking to that patient and understand, I know you're not going to recall all the information. Just tell me what you can remember right now that will help me take care of you medically. Okay. Here are some questions I have suggested for you. The first one is my favorite one. Domestic violence is so common, I ask all of our patients about abuse in the home. Great question to add. It's not, you're asking all of your patients, so that's the way it should be. Not if you just suspect it from happening, but asking them all. And every time you see them. Every time. We often see people with injuries such as yours, which were caused by someone they know. Could this be happening to you? You seem frightened and anxious. Has someone hit or tried to injure you? Do you ever feel unsafe at home? I'm concerned for your safety. And then a partner from a previous relationship. That previous relationship partner is stalking them. So they're making them feel unsafe. So it doesn't necessarily have to be a current. It can be a past relationship. So all of those questions are done non-judgmentally and in a caring way. So what if the patient says yes? I think that's the biggest fear of providers of all. Oh my gosh, they said yes, now what? Okay, remember back to that nurse EMT that I mentioned. You're not alone. You don't deserve to be treated like this. You are not to blame. Help is available for you. And you know, you may also be a victim of a crime and not just suffering injury right now. And then they do have the option. If they don't want to reach out at this time, let them know they can call the police. And then if they're an elderly patient, Elder Protective Services, if that's the route they want to go. And then, of course, our advocacy programs. In the state of Nevada, we do not have mandated reporting for healthcare providers for adult patients who are fully capable and functioning. We do have reporting for elder protective with elder abuse and also child abuse, but this may differ. California has mandated reporting, so please, if you are not sure about what your state requires, do that. I highly recommend that there is no mandated reporting for adult capable men, women, and gender nonconforming patients. They need to make that decision themselves because you will not understand what is safe for them. And now they not only have to deal with law enforcement and that person coming back after 12 hours, but now they have to be worried about an investigation taking place. So worried about that loaded shotgun above that child in that crib, you better believe it. So if you do have to mandate report, explain that to the patient, involve them in the process. Don't just say, okay, I'm leaving the ambulance right now, I'm going to make a call and this is what's going to happen. I'm just going to, I'll be back. No, involve them, call them right at that time if that's the situation that you feel that you need to report immediately, okay? Here's some important tips to reemphasize. Make sure they're in a confidential setting, that they are not just barred by a curtain in an ER situation or through a wall in a house. Don't make any promises you can't keep. Oh, the police department will protect you. Remember, highly volatile situations. Assess lethality and escalating danger. I am concerned for your safety. I have resources. Here's a small card that has the number for the hotline on it. And maybe you could tuck that into your shoe. And then at a later time when it is safe for you to do that, you can call that national hotline. The National Domestic Violence Hotline will immediately connect them to an advocacy program in the community that they desire. So that's a very good resource to give out, and that's the end of the presentation. Don't tell them to leave and everything will be fine. That is my biggest pet peeve, that, oh, don't worry about it, everything will be fine. And then you take them to the hospital and then they have a much more serious situation because you're not the diagnostician. Okay, everything may not be fine. So not a thing to say. And remember, 75% of risk of being killed if leaving. So leaving is not the way to go. It's up to them. If they want to leave, good, but they need a safety plan. If they say no, be aware of those clues, document those inconsistencies. Provide first aid, what you can, and then referrals. Discreetly is the thing I told you about the card, putting it in their shoe, or if it's a small card, put it in their cell phone case. That way they can access it when they want to. If they put it in their phones may be monitored, so they don't want to make that call from the cell phone. Make it from a safer phone. If the patient accepts, consider advising hospital security because that abuser may be following them. They need to be aware. And then if the patient decides, no, we're not going to transport, but just explain to them, of course, this is part of your procedures, the medical consequences if they don't transport, okay? And then sign your protocols, you know all of that. So the crime scene, minimize your effect on any kind of potential evidence, and then make sure you use the same entrance because you don't want to disturb any potential evidence. Advise the police of any injuries that you've discovered if that would support their reports. And then make sure the police have your contact information. You may be brand new on the crew, so make sure they have it. And then sit down with law enforcement ahead of time to talk about protocols for evidence collection. There are some new protocols for them, some other guidelines, so be aware of that. You are a partner with them on the scene. It's best for them to collect evidence, but there are some things that may not be involved in that because of your role in medical care. Okay. I have included with you, and we don't have time today to talk about some scenarios for providers. Not only have I provided you with some scenarios, there are 2 of them that you can do at a later time. Sit down at a staff meeting and then go over these and talk about some of the safety protocols, and then use the presentation I'm giving you today to assess those safety issues and next steps. But I've also included you an answer sheet with talking points, so you've got both available to you. And I also want to emphasize, take a look at a handout I provide on minimal elements for a domestic violence protocol. And you'll look at this and say, oh gosh, this was back in the 1990s. What's amazing to me is that we had this protocol in the 1990s and people are still not using it while numbers increase, increase, and increase. So take a look at those protocols and see if you can implement those into your care. Oops. So how do we determine a road to success? Don't judge your success in this situation by whether they stay or leave or they don't do anything. Remember, it's their decision. Did you provide them a safe, confidential environment for assessment and then possible disclosure? Success, if you did. Educational material? Success. In a discreet manner. Receive information about advocacy resources? Success. And then making appropriate referrals. Some people feel that referrals cost things. They don't. They're free and they're confidential, focusing on safety. So please reach out to them in your community. Here are the national resources. These are the ones that you provide to the survivor. Make sure you have those, put them in a laminated 3x5 card, have them available for you and for them as well. This is the National Health Resource Center where a lot of this information came from today. So I'm giving you that resource. These are some of the things that are involved that you can take a look at, but don't forget our own online healthcare toolkit. So let's take a look at our objectives to see if we've covered them today and then answer any questions. We looked at the scope of the problem, we defined what IPV is, looked at some of the dynamics, those medical conditions, and then really spent quite a bit of time on safety for you, and then screening and intervention and referrals. So I think we're coming close to our end of our, Troy. Are we doing well okay on time? Do we have time for questions?
Yeah, plenty of time. We've got about 10 minutes. So yeah, if you have questions, please feel free to write in using the chat function that I've sent a couple messages out through, or there's also the Q&A function that you can use. So yeah, we've got plenty of time, so please feel free to ask questions.
One question I have, Troy, is what do they think is the most important thing that they want to take away from the presentation? If they could respond in the chat.
Perfect, yeah. Someone said that the most dangerous time for the victim is when they try to leave.
Great.
What roles do nurses play?
I think nurses can be extremely important during the screening process and just showing that support. Just like the EMT nurse was with me in that situation, not feeling they have to apologize for asking those questions, saying that we care for all of our patients, so we're asking everyone these questions.
The most important thing I think to take away is to look for the signs and do not deny someone of their abuse and provide them with important resources to get them help.
Definitely. And remember that call to a national hotline will connect them to a local community advocacy program right away. And even if they're, say, for example, in Fallon, they may not want to have help in Fallon. They might want to go to California. So that's the benefit of the national hotline.
Another comment here, being prepared to help when they say yes.
Yes.
Thank you for sharing information about patients' non-compliance attributed to the perpetrator. Something nurses need to be aware of. Yeah, I think that's definitely something, yeah, to keep in mind.
I recommend people in clinics that in the waiting room that they might have a sign that says one accompanying a patient should be in the waiting room. And then there's a choice about whether the patient wants to invite them into the exam area or not.
Yeah, I think that's something that you've covered in your past presentations about how the abuser may force themselves into that exam room with the patient. Do you have any tips on what not to do as far as engaging with a perpetrator that may be present when we're helping a victim?
If they seem to be interrupting the care, that's where law enforcement comes in. They need to say, our priority is our patient care. Law enforcement, we need your help. If they're not yet on the scene and you proceed to provide care, remember I said about the towel. Get a towel or a blanket. Get something that would help to get them away, but they may not do that. They're very intent on staying with that partner.
If you could have a wish granted by other medical providers in the hospital or office setting, what would it be?
That they would implement routine screening for every patient every time.
I thought that's what you might say. Yep. Yep. Screening. Very important.
An appropriate response.
Any other questions out there as we get close to the end? Alrighty, I don't see any coming in, so thank you so much everyone for joining us today. Thank you, Judy. It's always great to have you here. You have such insight and great information to share. So thank you.
Oh, thank you for joining us. I appreciate it.
All right, bye everyone.
Bye.